there's a pair of kidneys. From the kidneys, ureters arise. The ureters, they empty in the urinary bladder, and the bladder in turn, it empties in the via the urethra to the exterior. And in males, there's another organ, the prostate, which is present, and this prostate is present. The urethra, it has to pass through the prostate, and then it empties to the exterior. So whenever there's the infection of the urinary tract, it can occur anywhere throughout the anatomy. Like it can be an infection of the kidneys, the renal parenchyma, or the ureter, the urinary bladder, or the urethra. In fact, there can be infection of the prostate also. That is prostatitis. So what happens is that bacteria are present. In case of infection, we need to have a causative organism. So the causative organisms can be bacteria. Mostly they are the bacteria, and these bacteria, they enter into the urinary tract. Then the white blood cells come along, and there's inflammation and infection of the urinary tract, leading to symptoms. So this is the repetition: upper urinary tract and the lower urinary tract. Upper kidneys are included in the upper urinary tract, and ureters. Kidneys, along with the renal parenchyma and all the collecting tubules, they are considered as the part of the upper urinary tract. And what is present in the lower urinary tract is the bladder, urethra, and prostate, as we just saw. And this anatomy, the difference in anatomy of the males and the females urinary tract, that in fact predisposes the females and the males to infections. Like the urinary tract infections are much more common in case of females. Why? Because of the anatomy of the region. Females, they have shorter urethra, and it is situated close to the vagina and the opening of the rectum, that is the anal canal. And we all know that the anal canal and the vagina, they are colonized by microorganisms, and there are hundreds and thousands of microorganisms residing in the rectum, in the GIT tract, and similarly in vagina also. So the organisms, they can easily migrate from these sites, the perianal area, the perineal area that is laden with normal flora. They are normal over there. These are normal flora of the rectum. If they stay in the rectum, they are part of the normal flora. If they stay in the vagina, they are part of the normal flora of vagina. But once they are translocated, they move from the rectum, their normal niche, which is the natural niche, and they enter into the urinary tract. There they can produce infections. So because of this, the anatomy of the female urinary tract, the urinary tract infections are much more common in females. Similarly, in males, we know that the urethra has to pass through the prostate. So in young adult males or the younger or in adult males, urinary tract infections are not that common, because the opening of the urethra and the rectum they're not very close to each other. But in older individuals, once there's hypertrophy of the prostate, then there's decreased emptying of the bladder, then the urine there's stasis of the urine. So because of that, they are predisposed to urinary tract infection. So the anatomy of the urinary tract infection plays a very important role in the pathogenesis of infection. These are a few definitions which you need to know. What is how urinary tract infection? What's the definition? So it's the combination of pathogens within the urinary system and symptoms or inflammatory response to the pathogen requiring treatment. So what happens is that there's the organisms, the pathogens have to be there. Then the patient has developed symptoms also, and these symptoms may be present because of the organism and also because of the inflammatory response of the body to the pathogen. So these things together, they are labeled as infection of the urinary tract. Then the urinary tract infections can be either uncomplicated and they can also be complicated. Uncomplicated infections are those infections which occur in a normal functioning urinary tract. The female, he just said that females are much more prone to urinary tract infection than males. So a normal female with having a normal anatomy of the urinary tract is more uh, uh, can get is more predisposed to UTI, and this is this can be labeled as this is labeled as an uncomplicated UTI because the it's the normal anatomy. Otherwise, there is no other predisposing factor to the infection. So, in uncomplicated UTIs, the urinary tract is normal, especially in um, this occurs usually in the females, normal adult females. What's a complicated UTI? In complicated UTI, the infection of the urinary tract occurs in a urinary tract that is either structurally, functionally, or neurologically is abnormal. How can it be structurally abnormal? They can be narrowing of the ureter, then they can be functionally they can be vesico-urethral reflux, which causes the urine to move backward. Then neurologically, it can be they can be the person can be paralyzed. There can be usually in paraplegic patient there's stasis in the bladder, and then the urine is a very good culture medium. So that this condition predisposes to infection also. Then there can be stones present in the either in the kidneys or in the bladder, and because of that there is structure abnormality of the urinary tract, and this so whenever an abnormality is present that leads to a urinary tract infection, that infection is called a complicated urinary tract. So this is the basic difference between a complicated and uncomplicated. Complicated is in an abnormal urinary tract, and uncomplicated is the urinary tract is otherwise normal. Then there's another terminology, asymptomatic bacteriuria. Asymptomatic bacteriuria is, as the name signifies that there are no symptoms. The symptoms are absent, but the patient is passing bacteria in the urine. So these normally with the voiding of the urine, all the bacteria they are flushed out and they are not able to lodge themselves on the epithelium and cause infection. So the bacteria it can be asymptomatic bacteria, but whenever there is a certain other abnormality, a complicated UTI can occur, and these asymptomatic bacteriuria can convert into symptomatic bacteria. Okay, so normally the normal flushing of the urine is a protective mechanism for the removal of the pathogens from the bladder. Okay, now what are the risk factors for urinary tract infection? We've discussed it again and again. Women and girls, they are much more prone to infections. Then sexually active women, they are much more prone to infections of urinary tract. Then changes in the vaginal flora. When menopause occurs, then the vaginal flora is changed. Initially, in vagina there are more gram-positive bacilli, there are lactobacilli present, but with menopause, because of the hormonal changes, the gram-negative bacteria they come and they start occupying the vagina. So the normal flora are changed now. Because of these changes of the normal flora, these flora which were are although a part of the vagina, but they can now extend into the more chances of reaching into the bladder and causing cystitis and then further infection. Then pregnancy also predisposes to UTI. Similarly, older adults, I just told you, they are more prone, and children are also more prone to get urinary tract infections. Structural problems in the urinary tract, such as prostatic enlargement, that again predisposes to infection. Poor hygiene can be a risk factor in all age groups and women and in men all. The poor hygiene is itself a risk factor for urinary tract infection. Okay, now complicated urinary tract infection. What we said is that urinary tract infection in individuals with underlying conditions that increase the risk and cause treatment failure, that is called complicated UTI. So, in complicated UTIs can occur in poorly controlled diabetes mellitus, in pregnancies, and in cases of functional or anatomical abnormality of the urinary tract. Functional and anatomical abnormalities can include renal failure. In renal failure, the kidney is diseased, is already diseased. There can be a number of other reasons other than urinary infection where the kidney can be damaged. And because of that damaged kidney, there is poor production of urine, then there less volume is produced, less concentration, the pH is abnormal, and the flushing action is also not there. So they can be renal failure can predispose to infection. Then urinary tract obstructions with anything, a calculus, whether there's a catheter, a stent, or anything placed within the urinary tract, that can also obstruct the flow of normal urine, and that can also lead to UTI. Then poor bladder emptying, as I just said, in case of prostatic hypertrophy in older adults. Adult males can lead to UTI. Vesico-urethral reflux is present, is mostly present in young children also, and because of this reflux, there's reflux of the urine into the via the ureter upwards towards the kidneys, and that can be recurrent. It can lead to recurrent UTIs and then pyelonephritis also. Renal transplant patients, they are already prone to increased urinary tract infection. And immunosuppressed patients, they are prone to all types of infections, and so they're more prone to UTIs also. Then there's another terminology, hospital-acquired urinary tract infections. Whenever a patient is admitted to the hospital, the patient can be catheterized. Then a number of medications are given to the patient, so the patient becomes more prone to urinary tract infection, and these infections are usually with multi-drug resistant organisms also. So the hospital-acquired and urinary tract infections are also quite common. Okay, now we know all this. The UTIs more prevalent in males, in men, women than in men, and older men are more prone than younger men. Then younger sexually active women of 18 to 24 years, they have the highest incidence of urinary tract infection. Okay, now in urinary tract infection, what we said was that there's a lower UTI and a upper UTI. So we'll start from the lower urinary tract infection. So first of all is cystitis. Cystitis, what's cystitis? Cystitis is infection of the urinary bladder. So there's the infection or inflammation of the bladder wall. This again is most prevalent in women. So I'm repeating it again and again that the UTI is normally more prevalent in women, and if the men they get UTI, then you should always suspect it's mostly complicated UTI. There must be, and you have to look for an underlying cause, because men usually are not prone to urinary tract infection. So what happens is that there's periurethral flora. The perineum has got a number, the normal flora, and then there's contamination from the gut, which can further cause contamination of the periurethral region also. And the perineal flora, they can cause lead to urethral colonization, and from the urethra, these colonized organisms, they can migrate to the urinary bladder. And from the bladder, they can further go upwards and cause ascending infection and can reach the kidneys where they're going to cause pyelonephritis. Inside the bladder, what the organisms do, they adhere to the uroepithelium. And this is the key. They have the bacterial virulence factors. They make these bacteria adhere to the epithelium of the bladder. And once they attach to the bladder, they start colonizing the bladder wall, and they enter through enter into the cells and cause infection over there. See this diagram, this is important, and if you just see this diagram, you will understand the pathophysiology. This is the urinary bladder, the urethra, then this is the rectum and the vagina. So here, the black things, these are microorganisms. So the rectum is colonized by the microorganisms, and the vagina is colonized by microorganisms, and this is the perineal area. So from here, the organisms, they colonize the perineum, and these are colonizers. Over here, they're not causing any infection. Inside the vagina, they're not causing any infection. But once because this is the normal niche of these organisms, once they are removed from this area and they ascend upwards using their virulence factors, and they move upwards into the bladder, if with the flushing action of the urine, when the urine is passed, most of these organisms, they pass downwards and they're expelled, and there's no infection. But if these organisms, they adhere to the walls of the bladder, they can cause they can stay over there, and the body, it produces an inflammatory response, and there's infection. So from the urinary tract, the bladder, they're going to cause cystitis here, and then after causing cystitis, if it is not cured at this stage, the infection can ascend upward to the ureters and to the kidneys also. Okay, so this is a uropathogenic E. coli. Most of the infections caused by most of the UTIs are caused by E. coli. That's the common, up till about 75 to 80% of the infections of the urinary tract are caused by E. coli. So what happens is the E. coli has got these P. fimbria or the pili, because with these pili, they attach to the cell wall. So these are all the E. coli. What they do is they pass upwards from the urethra, ascend into the bladder, and this is the bladder wall. Over here, they attach to the cell walls of the bladder. From there, they are internalized and they enter into the cell. Okay, now with the normal stuffing of the epithelium, many of these, they can be removed and flushed off. They are exfoliated and they're flushed off, but they can also, some of them can stay adhered, and they can cause infection of these layers. See, these are internalizing, they're going inside, and they're going to stay over there. Here the macrophages come, and you know that whenever there's inflammation, antibody reaction, there's inflammation and redness, and this inflammation is further going to damage the epithelium of the bladder, and because of the damaged bladder, there is a breach in the normal continuity of the epithelium, and further organisms can enter into the bladder and cause infection. So this was cystitis. Cystitis, that is an infection of urinary bladder. Now, as we just said, that the urinary the infection can, the microorganism can ascend from the urinary bladder, and they can move upwards via the ureter. So once they start moving upwards via the ureter, what they can do is they can reach up to the kidneys, and once they can reach to the kidneys, then they can cause infection of the renal parenchyma, and this infection of the renal parenchyma, that is called pyelonephritis. And once the renal parenchyma is damaged, then this what happens is healing is going to cause scar formation, and with the scar formation, the normal renal function is going to be impaired. So the pyelonephritis, it can further be of two types: acute pyelonephritis and a chronic pyelonephritis. Acute pyelonephritis, the name signifies itself, it's an acute condition. Okay, and it is generally a ascending infection, ascending from the bladder. So initially, the patient might be having cystitis, and if it was not cured, then it can lead to pyelonephritis. So what is there? There's bacteriuria. The bacteria are being passed, excreted in the urine. Then flank pain is also there. In pyelonephritis, flank pain can be there. Then chills and fever. These are all the symptoms of pyelonephritis: flank pain, chills, and fever. And this fever, if over here the pyelonephritis is not controlled, then the organisms can move from via the blood streams into the blood also, and it can cause bacteremia and sepsis. So this can be very become very dangerous, and it can be life threatening as well. The second type is chronic pyelonephritis. In chronic pyelonephritis, what happens is that the patient can be having recurrent UTIs. Recurrent UTI is infection or UTI which occurs about 3 times in a year. So whenever there's a recurrent infection, then with every acute infection, there is going to be scarring of the renal tissue, and this scarring of renal tissue will cause the loss of function, and there can be fibrosis and tissue damage also. And these infections might be new infections every time, or they can be a persistent infection, and if it's a persistent infection, then it will be more damaging, and it's going to cause renal scarring. So this is what happens in pyelonephritis. This is the normal kidney. You can see the shape of the kidney. It's a very nice convex shape over here, and the renal calyces. You can see the calyces also. In chronic pyelonephritis, the calyx also, it gets blunted. There is infection of the renal parenchyma and this is the renal pelvis and the renal tubules. So there's infection in pyelonephritis. There's infection of the renal parenchyma also and the renal tubules also. So the whole of the kidney can be involved, and it can be damaged. And then this can further lead to the formation of abscesses even on the surface of the kidney or around the kidney. So the pyelonephritis can further lead to the development of renal abscesses. And you can see the kidney has lost its normal shape, and with these scar formation, initially the kidney enlarges because of the inflammatory processes going on inside the kidney. But with time, with the formation of scars, it shrinks and it becomes functionally abnormal. There's loss of function of the kidney. Now, what's the pathophysiology? How does pyelonephritis occur? I think we've discussed it all. The uropathogen, it ascends to the kidney via the ureters. The bacteria then bind to and now in case of pyelonephritis, it can be secondary to other causes also. The risk factors such as the urinary stones are present, or if the patient is catheterized, then what happens is that this provides a nidus for the bacteria to attach. So if there's a stone, the bacteria, they're going to attach to that bacteria also. And so even if it was an acute pyelonephritis, the bacteria, even with treatment, they're not going to be completely cured, because they are attaching themselves to the stones, and sometimes the patients are catheterized, but they cannot pass urine. Long-term urinary catheters are in place, and these urinary catheters, what happens is that the organisms, they can form biofilms, and they attach to the urinary catheters also. So after ascending from these nitises, the urinary catheters or the stones, there's constant shedding of the organism and progression of the disease. Infection can occur if bacteria retain in the urinary tract by physical obstruction. So the bladder stones and the catheters or the stents, nephrostomy tubes, they can all cause the physical obstruction. And because obstruction is present and then the infection is occurring, so what kind of infection it is? It's a complicated infection. It's a complicated UTI because the normal anatomy and the normal function of the kidney is not there, of the urinary tract is not there, so that it is secondarily it's leading to the development of infection. So this is a complicated infection. Now this was, I was telling you about the ascending infection, but at times there can be hematogenous stealing of the bacteria. How does it occur is that there's blood, there's an abscess somewhere else, but with the hematogenous spread, the bacteria enter into the bloodstreams and they can be taken up to the kidneys, and from and there they can lead to the suppurative necrosis and abscess formation. And mostly it's the Staph aureus. Many of the bacteria, any bacteria can cause it, but Staph aureus is especially known to cause be spread by hematogenous spread because it can cause metastatic abscesses. So whenever there's an infection of Staph aureus is someplace in the body, it can be transmitted by hematogenous spread to other parts of the body also. So similarly, it can, like it goes to other parts, it can be transferred to the kidneys also. So in severe cases, the kidneys can be enlarged with raised abscesses on the surface. I just showed you because in the initial stages, the kidneys become enlarged and the abscesses, they can be seen on the surfaces. But later, because of the scarring or the healing process also going on, this the renal parenchyma undergoes fibrosis and the kidneys become smaller in size. Then the renal abscesses. Renal abscesses are formed after there's chronic or recurrent urinary tract infection or the pyelonephritis. And these abscesses, these infections can further disseminate into the surrounding areas, and they can around the kidneys, and they can form perinephric abscesses. Then within the kidneys, renal abscesses can form, and these within the cortex or the medulla of the kidney, the abscess can be formed. So cortical medullary abscesses can be there or cortical abscesses there. And at times they can even extend into the gut or extend upwards into the lungs or the pleura. Then there's another terminology, catheter-associated UTI. This occurs in those people who are catheterized, especially because once the catheter is inserted, there can be contamination. Even during the passage of the catheter, there can be contamination. The organisms can be pushed into the bladder from the perineal, from the perineum. But then there can be, once the catheter is in place and it's a long-term catheter, then what happens is that biofilm forms on the surface of the catheter, and biofilms are actually colonies of the bacteria, and these bacteria, they can cause infection. Even after treatment, the antibiotics cannot reach those biofilms, and so there is persistence of organisms within the urinary tract, and can cause infection over there. Then the duration of catheterization is also important, and if there are certain other diseases along with catheterization, they also predispose the person to infection. Then prostate present in men, it can also get infection, and it is usually prostatitis can occur, and they can repeated infections can lead to prostatic infection, and then prostatitis also there's dysuria frequency and fever can also be there. And prostatitis also occurs with gram-negative bacteria. So what are the stages of the urinary tract? First is there's entry of the or microorganisms via from the perineum into the urethra to the urinary bladder. From the bladder, they move upward to the ureters into the kidneys, and in case of severe infection, they can even cause sepsis and involve other parts of the body. Generalized sepsis can also after the urosepsis and then sepsis. And this is a life-threatening infection. So what are the causative organisms? See here, they are grouped according to the type of infection they cause. Complicated UTI, uncomplicated, catheter associated, and recurrent UTI. Now look, you can see the names of the organisms. First and the foremost is E. coli, the most common infection which causes urinary tract infection. Here they have labeled it with uncomplicated UTI, but in complicated, the organisms are similar to uncomplicated UTI, and over here also E. coli is the first, the foremost. So in all these cases, the most common organism which can cause urinary tract infection is E. coli. After E. coli, there is Enterococcus, Klebsiella pneumoniae. These are all enterobacteriaceae residing in the gut of the they are part of the normal flora of the patient of the gut. So all these organisms, they can cause infection, but E. coli is the foremost. In case of complicated UTI, what happens is that most of these organisms, they become antibiotic resistant. So complicated UTI can be caused by organisms which are resistant to antibiotics. Pseudomonas aeruginosa, Acinetobacter, Enterococcus, Staphylococcus, these can all cause complicated infections. Then other organisms, Proteus mirabilis, it can cause complicated, uncomplicated, catheter-associated. These are all Enterobacteriaceae, and these Enterobacteriaceae can cause UTI. So you can see that there is an overlapping of the causative organisms which can be present. E. coli causing 75 to 95% of both uncomplicated and complicated UTIs. So this is the most common organism. Then there's Staph saprophyticus. Staph saprophyticus, it causes infections in sexually active women. So it causes 5-15% in sexually active women. Because E. coli is in all types of, in men, women, in complicated, uncomplicated. E. coli is the most common organism, but saprophyticus, it is common in sexually active women. Then all the other organisms, they can all cause infection. Klebsiella pneumoniae, saprophyticus, Staph saprophyticus, group B streptococcus, Proteus mirabilis, Pseudomonas aeruginosa, these all organisms can cause infection of the urinary tract. I just told you the Staph aureus, it is mostly by hematogenous spread, and that can lead to renal abscess formation. Then Candida species, they, especially in patient of having urinary catheter and having these indwelling catheters and receiving antibiotics, Candida species will cause infections in those patients. Similarly, Corynebacterium species, these urelyticum, it can cause infection in patients with having indwelling catheters. So what are the clinical presentations? Cystitis and pyelonephritis. Cystitis, it has, the patient will come to you with dysuria, hematuria. Dysuria is painful ventilation or burning ventilation. Then hematuria, frequency, and occasionally there can be suprapubic pain. And this pain is because of the inflammation of the bladder wall. So the patients, they will tell you that they are having suprapubic pain. Okay, so in case of pyelonephritis, all these can be there. Dysuria can be there, hematuria can be there can be suprapubic pain because it's maybe there's initially a cystitis which is going to, in case of acute pyelonephritis, the cystitis may also be present with pyelonephritis. But in pyelonephritis, the basic difference is that there is going to be costovertebral angle tenderness or flank pains. patient will put his hand on the back and they're going to tell you that this is the place where I'm having pain. Then fever, chills, nausea and vomiting. These are also um, common features which accompany pyelonephritis. So in addition to all these features, if a patient comes with a costovertebral angle, pain, tenderness, fever, chills, nausea and vomiting, then we should always think on the lines of pyelonephritis, and this is most probably if it's a young male, you should always think that there may be an underlying pathology. There can be a stone present which has led to the development of this infection. Okay, so how do we diagnose urinary tract infections? By urine analysis. And in urine analysis, what we do is we perform microscopic examination also, and then we do culture. So first of all, it has to be a clean catch urine, and then there's physical and chemical examination. Physical examination means you see the color of the urine, specific gravity, pH. The pH of the urine is slightly acidic, but in certain cases, like in Proteus, if the infection is by Proteus, the Proteus is a cause of infection, then their pH becomes alkaline. So if the urine is alkaline, you should always suspect that the infection can be due to Proteus. Then nitrites are present in case of Enterobacteriaceae. Nitrites are present in the urine, and protein can also be present. Microscopic examination is going to reveal. We're not going to go in detail of all this because I think you have another lecture about the urine analysis and urine ER. So RBCs can be present, pus cells, casts, and crystals are going to be present. So when do we label it as pyuria? That normally also WBCs 2 to 3 or 1 to 2 WBCs can be present in urine, but if more than 10 WBCs are present, then we are going to label it as pyuria. That is, the patient is passing pus urine. Bacteria alone is not a disease. I just told you that bacteria can be present in the urine, but they can be flushed off. It's the symptoms which cause infection. For symptomatic UTIs, most patients have more than 10 WBCs per milliliter. Then the presence of nitrite on urine analysis is also a marker of UTIs, because all the Enterobacteriaceae, they are positive for nitrite. Their nitrates are converted to nitrite. So E. coli, Klebsiella, Enterobacter, and Proteus. If nitrite is present, you should suspect an infection with one of the members of the Enterobacter. This is how we do it in the lab. This is a strip, and it has got it's color coded, and the color change is noted down. And we can, from here, we can see the pH, where the protein is present or not. This is the microscopic examination. You can see the WBCs. These are the WBCs are the pus cells. And can you see the bacteria? Look at the amount of bacteria. RBCs are also present. These the circular ones are the RBCs. These are the RBCs, and the granulated ones, these are the WBCs. Okay, once we see that the patient has pus cells in the urine, has the symptoms, then in order to find out the organism and to have the sensitivity of the bacteria, you need to perform a culture also. And the culture should be obtained before starting antibiotic therapy, and it should be a clean catch urine. The urine should be collected in a way that it does not become contaminated with the periurethral flora. And you've seen, if you've ever seen a culture report of the urinary culture report, what we write is that the organism, we give the colony count, the number of organism. If the colony count is about 10 power 5 colony forming units per ml or greater, then it means that there is infection of the urinary tract. So this is how this is the clear medium. This is where this is used for culturing of urinary samples. once cultured, this is how the urine is cultured. The straight wires, the loop is taken, and a drop of urine is spread on the clad plate. Okay. This is clad agar. It's green in color. Then the next day we come, we get these colonies. This is most probably E. coli, which is growing on the head medium. And this is how the urine is plated on the agar. Then after we get the growth on agar plates, biochemical tests are performed in order to identify the different organisms. And finally, this is the sensitivity plate. These are the antibiotic discs which are placed on. This is a lawn of E. coli. The E. coli is spread over here, and sensitivity these antibiotic discs are placed. And these zone sizes or the clearing of the area, these show that this organism is inhibited by this antibiotic. This is augmented, and you can see that there's no zone of clearance. That means the E. coli which has been plated on this plate is resistant to augmentin, and if we give augmentin to the patient, it's not going to work. So just quickly go through the few organisms which are the most common. E. coli is the most common cause of urinary tract infection, and this is because it has certain virulence factors. It has got P. fimbria, and these fimbria we just saw in the previous diagram that they help in the attachment to the endothelial cells, and then it can also secrete lipid A. And this lipid A, what does it do? It has a paralytic effect on the urethral peristaltic epithelium. So because of this, there can be stasis of the urine. The urine can be reflux upwards also, and they can be ascending infection from the bladder to the kidney. So that is why E. coli is the commonest organism which can cause urinary tract infection. Then there's another organism, Proteus. It is also in the part of Enterobacteriaceae, has a number of virulence factors, adhesions. It is a motile organism, and it can form biofilms also. So it can form biofilms on the catheters, on the stones, the renal stones. Then it can adhere to the epithelial surfaces and to the foreign bodies which are present, the stents which are present. And it is a highly motile organism. It can extend upwards also. Then if the one important characteristic of Proteus is that it produces urease, and this urease, it can split urea into ammonia. I just told you that urine is slightly acidic, but if there's infection with Proteus, it's going to become alkaline. So if you see a DR report which has the pH value is 7 or 7.5, somewhere above 7, then you should suspect an infection with an organism which is splitting the urea, and it is causing the pH of the urine to become alkaline. So this is a characteristic feature of Proteus. Then it has got swarming motility. See, this is one Proteus colony which was present. One colony was present on the agar plate, and it has spread out like this. This is called swarming motility. These can with their flagella and the fimbria, they can move around or on the agar plate. It does not stay over here. It moves around, moves outwards and covers the whole plate, and it has a very bad fishy odor also. And these are infection with Proteus is associated with the formation of renal stones, and struvite stones are present. These are calcium magnesium oxalate stones which are common in case of infection with Proteus. Pseudomonas is also gram-negative rod, not an Enterobacteriaceae, but it is gram-negative, and it is common in hospitalized patients, hospital-acquired infection. I just told you that there can be hospital-acquired UTI. So Pseudomonas aeruginosa is one of the organisms causing hospital-acquired urinary tract infections. Enterococcus. Coccus, it's not a rod, it is a round organism as you can see in the picture, and it is gram-positive cocci. So gram-positive cocci, it is not a very virulent organism, but it has the property of forming biofilms, and because of this, it is can lead to catheter-associated urinary tract infections and in hospital acquired UTIs. It's quite common. Then is Candida. Candida is a yeast, and it the most common is an infection caused by Candida albicans, and it is especially common in diabetic patients and in case of catheterized patients and patients who have taken antibiotics for a long time. So what happens is the antibiotics, they don't just kill those organisms for which they are being taken, but they alter the normal flora also. So when there are no normal flora, then the Candida, they are going to proliferate over there, and they can cause infection of the urinary tract. And then they also have adhesins and secretion, they hydrolases, and they can form biofilms. So Candida can also cause urinary tract infection. What's the treatment? Treatment is you have to dilute the urine. If there's hydration, there's dilution of the urine, and this dilution, it helps to remove uropathogens, and with the flushing action, frequent emptying of the bladder, the pathogens are going to be flushed off. So this is a part of the treatment and prevention also, to be hydrated and keep the urine diluted. Asymptomatic bacteriuria, that is, symptoms are not present, but bacteriuria is present. It is generally does not need treatment, but in case of pregnancy, the pregnant women, it has to be did. This is one of the conditions in transplant patient and in asymptomatic in pregnancy. Asymptomatic bacteriuria has to be other with oral antibiotics. The antibiotics which are generally used, the antibiotics actually have to be based according to the sensitivity testing. If the cultures are performed, then according to the culture and sensitivity, antibiotics are to be given. But commonly used antibiotics are ciprofloxacin, Septron, this is Septron, trimethoprim, sulfamethoxazole, and toxomycin. They have these good urinary tract penetration, and these are used for the treatment of UTIs. So this is basically the urinary tract infection, and now I hope you people did understand what was being taught, and if there are any queries, you can always ask me. And I'm going to upload the questions now, and you have to attempt those questions, and they will be marked on those questions. Okay, so that's it for today. Okay, thank you.